Dear colleagues and friends, I'm glad to see you on our channel. I hope it is interesting for you, and if you have any questions, please write them down. Now I want to continue and finish in this video a review of our clinical case with deforming arthritis and to deal with the theme of the stage of permanent prosthetics. So what do? We've removed the problems that the patient addressed to us. After that, we can finally start directly to our work. This is dental prosthetics. We take working impressions. Here is the XIF system was used for implantation. We do not use the system, but I can provide prosthetic work on almost any system. There is no problem with that. Although, of course, it is quite as tricky as you can see. There are special caps for transfers. Then additional registration is carried out. Next, we again register the ratio of the jaws, register the position of the upper jaw with the use of a face bow, and remount our working models. Now I don't dwell on this. We make a collapsible base. There is a special video on this topic. You see, this is not an isolated case. In almost all cases, we make a collapsible base in order to work clearly and control the work of both the technician and our own. A central ratio register. You see, we've already got the permanent work. There is no patient yet, but what do? I provide registration. We carry out the registration of these crowns and mount on the articulator once more. In this case, these models are already mounted on the articulator and I can fit the register very accurately. And then I register the central relation for permanent work. The permanent work is mounted on the articulator again and I can check it. In this case, we have already received work from another city, so it was packed this way. You can see that we have a well-formed occlusion. You can see that the inclination of the teeth corresponds to what is needed. This is what I said at the stage of temporary prosthetics. It is very important to find a common language with technicians. You have to say, yes, it's bad, it's good, green, blue. We must say how to fix this situation, and you have to understand this too, but not just giving it all to the technician. We install the individual implant abutment, check the proximal contacts again due to the fact your crown may simply not fit. And here is this question very important because we talk with you about the accuracy in microns, but a crown may not fit. So here all these points are evaluated or checked. The second point, once again, what do? I tightened it. After a while, I pulled it out because the torque force must be undertaken, but you tighten it in two steps so that the voltage in the metal that would not allow the screw to be unscrewed. Here I tighten the screws one more time. I install the crowns and can already move on. You can see that I check every crown. Install, check. On the left and right sides, I control every movement, every crown. You see that in this case, not all fits good, but I work hard and fit everything up to the end. Very often, implant pitches are closed with Teflon. This is a plumbing material. Colleagues, don't do this. I use good aperture to close the implant pitch, and I argue to do so because, pay attention, the patient got to us for about several months. She had a Teflon pitch, and at the time of the treatment, it all looked terrible. Good aperture is warmed up. It has been serving for more than 100 years to close various kinds of teeth canals, but you can also seal an implant. So we close, fix, and start checking the occlusion. We check the contacts that our patient has. In any case, several other contacts may also appear in the oral cavity, so we carry out grinding. At this stage, it is clear that we can grind a lot. I take an 8-micron carbon copy paper and place it in the area of the implant. I can hardly pull it, but in this case I see that there is an insufficient density of contacts. Yes, and if you remember, I haven't made just crowns, but made prototypes. I take an impression with those crowns that I fixed, and those crowns where the density of contacts is not enough for me, I checked with articulating paper and used silicone for impressions and saw that the density of contacts was not tight enough. I take impressions to fix it. Pay attention, I fill the crowns with a fast hardening composite and get such an impression. The situation is the same on the model. I can easily put through a copy paper between these crowns and the antagonists. Therefore, I sent these crowns back to the laboratory where they improved them. That is, once again, if at the stage of temporary prosthetics I could simply take a composite, then at the stage of permanent prosthetics, if your technician overlooked something, you won't be able to supplement it. And pay attention, even on the model the crowns hold the carbon copy paper as well as in the mouse. That is, there is a gap for some reason the dental technicians have not created the cusps in this area good enough. Therefore, we send the work to the laboratory and pay attention. At the final stage, I checked the occlusion. On the front teeth, I got 100 microns point contacts, because the greatest density and load should be formed on the site. Check up premature contacts and look what we got. A clear hit in the occlusal support fissures of our contacts. We have completely worked out the whole scheme. You see, such a very tight contact has appeared on the front tooth. I have to grind it too. In order not to stress the patient too much, you often use rubber burrs for this, and we polish. Everything that you did, everything you grinded in the oral cavity should be well polished. And as I said earlier, this patient later decided to have anterior teeth prosthetics, and if we had this opportunity before, of course we would have planned our treatment a little in a different way. We prepare teeth, install retraction cord, and this is already a matter of technology. Very often doctors brag about how beautiful they made front teeth, but more often the technician does them beautifully. The doctor summons them beautifully. Prosthetics of the anterior teeth in this case was a matter of technology. We fixed the work and the patient is satisfied and happy. There are no complications or chips. In this case, I didn't make a night mouth cut, although in such patients it is of course indicated, as well as generally chronic treatment of a chronic disease. You should check them periodically. Every 6 months or a year you should give them an MRI, supportive therapy, and assessment of rheumatoid factors, and there are many other things that need to be controlled. Please note, in spite of everything, the mouth opening will still be with a deviation, since the joints are different. And then we have an assessment of permanent prosthetics. We have no complaints, no hypertonicity, no problems in the area of DNG. The capsulitis is gone. We removed all acute problems. The occlusal index is very low. The patient wasn't simply undergoing prosthetics, but one could even say that he was rehabilitated. After all, rehabilitation means not just replacing the enamel of the patient's teeth with crowns, but it means treatment, because the person has undergone rehabilitation. That is, there is a phase of active treatment, after which the patient comes to a phase of rehabilitation. It was like this with this patient, and thank God everything is fine with him. Colleagues, if you have any questions about this case or others, we'll be happy to answer them. Please subscribe to our channel, ask your questions like the we did, invite friends. We'll be also glad to see you at courses and online events. All the best. See you.